Spinal cord injuries. So we're talking about spinal cord injuries. There's really not a specific way that we really locate it. We can say the location based on which spinal column area we have, but that's really the only location specifics that we have. So it really can occur on any level or area along the spinal canal, spinal column. Depending on the source of the force, so some type of force that has occurred that has been directed at the spinal cord or spinal column, that's going to result in the damage of either your vertebrae, and then the vertebrae can actually cause the spinal cord injury or sever that spinal cord, or it's a direct impact to the spinal cord itself. Anything above basically C3, pretty much guaranteed death at that point. Anything below, it's going to be kind of dependent on the patient, what kind of symptoms they have, what type of nerve endings that die, what's affected from there. Classification-wise, we classify it as a complete or incomplete spinal cord injury. With your complete injury, everything has been eliminated below the level of the injury. So if I have an injury at C7, everything below C7, all my nerve endings, all that nerve wiring that affects all the movement, my bladder control, how I move my arms, my diaphragm, how I breathe, anything below that injury is going to be completely affected. It eliminates all that nerve ending. That's going to be your complete. Your incomplete, more common, still allows a little bit of function below that level of that injury. So it's not a complete cutting off of your nerve endings, of the movement, of your breathing, of your bladder control, your GI control. Most of the time it's going to be just kind of weakness, a little bit of sensory perception issues, bladder control issues, sometimes some bowel issues as well. Now, mechanism of injury. Another way we can classify it. Primary injury, that's that direct force, that direct impact to that spinal cord. Secondary injury is going to be like the secondary effects related to the injury. So if I have, let's say I fracture my C7 vertebrae, if I have any kind of swelling or edema, any type of injury to the vasculature within that space, that's going to cause like decreased perfusion to that area, causing some of those nerve endings, causing some of that spinal cord to be damaged. And I have that ischemia involved with it that could cause a spinal cord injury from there. So that's what's going to be my secondary involvement. Nothing direct impact directly related to the injury. It's all the secondary effects, whatever happened because of that injury. That's how we're going to distinguish the true primary versus your secondary type of spinal cord injuries. Can anybody name some type of big force, some great force that can cause a spinal cord injury? A big impact. So car accident, good, that's always a big one. What else? Falls, good.
Gunshot wound.
Gunshot wounds, what about a knife wound?
Any kind of penetrating wound.
Diving, swimming, that kind of stuff.
Comfort test, do we need to know the numbers next to
Not necessarily, but if you think about it, what time you eat your food, that's how I think about it.
Yeah, I do too. Cereal at 7, lunch at 12, or turkey at 12, and lasagna at 5.
I usually do breakfast, lunch, and dinner, 7, 12, and 5. Then I have a snack at 5 as well. So.
Thank you very much.
But you don't have to necessarily do that. All right, so let's talk about a primary reason, your primary mechanism of injury. When we're talking about the mechanisms of injury. There are 5 primary mechanisms of injury. So let's get a volunteer. Natalie is front and center, so stand up for me, Natalie. Let's talk about hyperflexion, all right? So extend your neck, put your chin to your chest as much as you can. See how she's bending her neck like that? She's hyperflexing her neck. That's what's causing this injury to occur. So as she's bending over, she's causing a lot of stress, a lot of strain within that neck. But don't think about it just within the neck. It can also be in the thoracic space, thoracic vertebrae as well. It can also be within your lumbar and sacral part as well. But any part that bends that spinal column forward or kind of back. So as she, again, puts her chin to her chest and she's bending that neck, that's causing that hyperflexion injury. So sudden and forceful acceleration, some type of movement of the head forward, causing extreme flexion of the neck. That's our hyperflexion type of injury. All right? Hyperextension. So, Natalie, put your chin to your chest and then put your head all the way back as far as you can.
Well, I'm sorry.
Chin to chest and then head all the way back.
How does that work? Wait.
Bless it.
Like you got whiplash.
Yeah.
Okay.
Yeah, just like that. Boom.
Oh,
Okay. Apparently I didn't pick the right volunteer.
I think
All right,
we're
so
talking about doing it at the
I thought
same
you were going to
time.
say something. I was like, that doesn't work. Like,
no, one and then the other. There you go. Okay. So did everybody see her? As she moved her head forward, she moved her head all the way back, kind of have that whiplash effect. But that's that hyperextension part. As she moves her head fully back, I have that sudden acceleration and deceleration of the head. And the stretching and tearing that anterior longitudinal ligament. It can also cause dislocation. It can also cause fractures within that vertebral column, okay? So that is my hyperextension. Axial loading. You cannot volunteer for this one. Excessive.
What is
We'll get to it. Let's go to excessive rotation. We'll come back to axial loading, all right? So look as far back behind you as you can without moving your shoulders or anything. Almost like an owl. No, that's not how an owl moves. Yeah, turn your head all the way around. Okay? Axial rotation. So moving that head past the point of where it cannot move no more. So if you think about in those villain movies or the assassin movies where they break their neck and they spin it all the way around, kind of like an owl, that's that axial rotation. Okay? And then we won't have to do penetrating trauma on you as either, so you're good. Thank you, Natalie.
Okay.
All right. Axial loading.
I just love that.
We love you.
Okay. I have my vertebrae, then I have my disc in between it. Axial loading, a lot of increased force or pressure along your spinal column itself. It kind of crunches in on itself, kind of presses on itself. That's what I'm thinking about with axial loading. So vertical compression that results in the vertebrae shattering. Potentially the bone fragments, so if I have a little fracture right here, it could actually break off and cause an injury along that spinal cord. Enters the spinal canal and damages that cord. So we'll think about that. So if I decide to jump off a 4-story building and I land on my feet, all that force of gravity against the ground, that's going to compress my vertebrae, right? We see a lot of these injuries with pilots, fighter pilots. They're under a lot of continuous stress all the time. Taking off, landing, all those G-forces that they pull, that force of gravity forcing against them. Sometimes they'll be even a little bit shorter when they land compared to when they took off. I heard a story of a guy that his plane malfunction or something like that, and then his parachute didn't deploy as it should have, and he basically hit the ground, fracturing a lot of his vertebrae, and now he's like a foot shorter or something like that, and he didn't have height to begin with. But so axial loading, that's what we're thinking about there. Penetrating trauma. There's two different categories for penetrating trauma. So there's low impact and there's high impact. High impact is a big excessive force, high impact force. So something like a gunshot wound, that's very high velocity, causing a direct and indirect type of wound. So direct, directly to the spinal column. Indirect, around the spinal column. So it's some of those vertebrae, maybe shattering it off, breaking, causing some issues with perfusion, maybe some edema, some swelling with it as well. So that's your 5 primary mechanisms of injury. Questions about the primary mechanisms of injury? No? Okay. All right. So something like a car crash. Car comes in, hits a tree, maybe another oncoming car, causes that neck to kind of snap forward, right? And you have that hyperflexion of your spinal column, of that cervical spine. So that's where you get that dislocation. You might have some disc impairment as well. You might have some bone fragments that kind of pop off, causing a spinal cord injury.
Is this the one you said they die instantly?
Depending on the level of injury. So above C3 or higher is pretty much guaranteed.
What is called decapitation?
Yeah, you can have decapitation where you, not like the true decapitation like you think about, but you can be decapitated with your head still attached.
Like a cervical dislocation.
Yeah.
Does it count? I can't remember. I used to know. Does it count up or down? Like
Counts down.
1, 2, 3.
No, it's down.
So you got
C1's at the.
C1's at the very top,
Okay.
counts down.
I don't know why I thought it was opposite.
So 1 through 7, and then you have T1 through 12, L1 through L5. So it starts at the top, works your way down, but you don't go 8, 9, 10, 11, 12, 13.
You start over.
You start over with each section.
That's what I'm thinking. Okay.
Okay. So yeah, this first picture is your hyperflexion type of injury. Second picture, something like a whiplash type of injury. Hyperextension injury. So all that force is causing that head to snap back, to whip back, causing that ligament injury, but also compression of that spinal cord, potential fracture of some of the vertebrae. Here's your axial injury right here. So let's say 9-year-old Meemaw fell onto her bottom. They already have weak skeletal system anyway, right? So any type of little fracture because of that excess force that's being applied to that spinal column. Same thing with diving injuries. So you'll see a lot of these, a lot as well. Getting hit on the head, causing that compression, that crunch of that vertebrae. So you see that compression fracture right there, and see how it's kind of compressing along that spinal cord. So we can have a complete severing of that spinal cord, causing complete paralysis, complete symptoms, everything that you're going to see, complete loss of all the nerve endings below the injury. And it's kind of backwards right here, so you think it's going to maybe fracture right here, but it's also down from your injury. Okay. secondary mechanism of injury. Remember, these are types of things that are caused by that primary injury. So no direct impact or direct force that's applied to the spinal column itself, but something as a result of that direct force, something as a result of that primary mechanism of injury. So things like a hemorrhage, ischemia, anything that causes perfusion issues to that spinal column and to that spinal cord, that's going to cause issues as a result of that primary injury. Once I have that ischemia and I have that nerve death, then I'm going to start to lose my sensory perception, my ability to walk, maybe my ability to breathe, maybe the ability to move my arms. Hypovolemia. Remember, we have that neurogenic shock. I want to increase my perfusion as much as I can. That injury is going to cause the vasodilation of those vessels along that spinal column. That's why it's so important to increase that perfusion. That's why it's so important to increase that fluid intake. Restore that perfusion. And maybe just some localized edema. That may get better with time. Maybe I give them some steroids. Give them a little bit of time, causing that edema and swelling to go down. And it doesn't cause that core compression. And then my symptoms may kind of disappear over time. So that's what we see. If you see it, there's kind of a bulging area right here along your spinal. And it's causing a little bit of compression along that spinal cord right there. Okay. Big two things with your secondary mechanism of injury: core compression and decreased perfusion. If I can resolve that core compression and I can increase my tissue perfusion, I should be okay. Questions about secondary mechanism? Assessment-wise, biggest thing, ABCs. Always remember ABCs. I know y'all get tired of hearing this, but airway, breathing, and circulation. That's going to be your number one thing. Make sure they have an open airway. Make sure they are breathing. If not, let's place an advanced airway and take over their breathing for them. And then lastly, their circulation, of course. Vitals, let's look at their vitals. Let's make sure they're maintaining their blood pressure. Make sure their heart rates are under control. Make sure that heart's not compensating for that blood pressure. I'm looking at airway. Make sure my O2 stat's where it needs to be. Make sure my ABGs are appropriate. GCS, what is that? Glasgow Coma Score. Good. What does that measure?
It's your neurological assessment to determine.
Overall, just alertness, but it's that big neuro assessment. It's a few slides down. We'll talk about it. Going further in my initial assessment, I also have that spinal shock, very similar to a neurogenic shock. But I have a complete loss of my motor function, so my movement, my ability to move my upper extremities, my lower extremities, my sensory perception, being able to feel different things. So if I'm touching my patient's legs, he may or may not be able to feel that. Those deep tendon reflexes, I may lose those. Usually that's going to less than 48 hours with your spinal shock. If I restore that perfusion, get rid of that edema or treat that edema, decrease that swelling, these symptoms should resolve over time. And then I can kind of evaluate the true seriousness of my injury. What are going to be kind of the longer term effects of my injury? When assessing my sensory and mobility, I'm assessing the level of injury. What does that mean to me? So that lowest neurologic segment, that's intact. My highest level motor function, where I'm able to kind of move different things, where I'm able to sense different things, that level of that injury. Level of injury is a little bit different than exactly where the injury occurs. All right? It's where I can feel, where I can move. Quadriplegia versus paraplegia. So your quadriplegia is what? All four extremities, right? You also see it as tetraplegia as well. Sometimes they'll interchange those, quadriplegia or tetraplegia. And then paraplegia, just your lower extremities. All right. You also see what's referred to as quadriparesis, which is just weakness. Weakness in all four extremities, compared to the quadriplegia, which is inability to move. You also see paraparesis as well, so just kind of weakness, overall weakness in the lower extremities. And then we have, for sensory-wise, hypoesthesia versus hyperesthesia. Decreased sensory perception. So hypoesthesia, decreased sensory perception, or hyperesthesia, increased sensory perception. Almost like I even look at their arm, they can feel it. One of the two. Cardiovascular-wise, what kind of things will we expect? What kind of things could we potentially see assessment-wise? If my autonomic function, my nerve function is impaired, my cardiovascular system is going to take a hit, right?
Mm-hmm.
So things like bradycardia, my heart's not beating quite as fast. I'm inability to have that vasculature tone. So I may have some hypotension. So how am I going to fix that? Fluids, vasopressors. All goes back to that neurogenic shock, right? Trying to increase that perfusion as much as possible. Trying to keep that mean arterial pressure above 65. That way I know that my perfusion is adequate enough. Right. What about my respiratory system? What kind of things can we think about? Any guesses? Tachypnea, maybe. Irregular respirations, right?
Mm-hmm.
I gotta have nerve endings to make myself breathe, right? A diaphragm doesn't just contract on its own, right? All the thoracic muscles, those muscles that are involved in that act of respiration, that breathing in and out, all those are going to be affected. So anything nerve ending wise that may affect that, I gotta consider that, gotta think about that. So that's where about advanced airway, thinking about that advanced airway. The higher the level of the injury, so if you get up into that cervical column, the more of this stuff I'm gonna lose, okay? Our goal with respiratory-wise, main thing is just maintaining that O2 sat. Maintain that O2 sat. Remember, we might have to potentially collaborate with others. Might have to get respiratory therapy involved. Might have to get the physician involved as well. Coordinate that care. GI-wise, is it going to decrease my motility of my bowels?
Depending on where the lesion's at.
Depending on where the lesion's at, right? but for the most part, it's going to cause some type of GI motility. What if I'm not getting out of the bed?
GI stasis.
So even just like somebody that doesn't have a spinal cord injury, basically every patient you take care of, do they have GI disturbances at some point? They're not getting up, moving around, not getting that GI tract moving, getting those bowels moving. Mobility is important for several different factors. GI is one of them, all right? If I have that immobility or my motility is impaired within my GI tract, what can that lead to?
GI perforation.
GI perforation, something a little simpler than that though. Ileus, maybe an ulcer, right?
Constipation.
Constipation, those kinds of things. All right, so if I have the potential for ulcer development or an ileus, constipation, what are some good medications that I might need?
Protonic.
Protonics. Everybody gets Protonics anyway. That's always a good answer to click, right? Everybody needs Protonics. But yeah, some kind of PPI, something that's going to help me protect me against my ulcer development. Just remember, they're getting a lot of pain medications. They're getting a lot of steroids, a lot of things that are going to cause that motility to either stop or be impaired. Plus the nerve endings, the nerve injury that's going to occur with this spinal injury. GU. The GU is really going to focus on that bladder and that bladder control. Usually with your high thoracic and you're still going up into your cervical injuries, that's really going to kind of spare the lower spinal reflexes, but it's going to actually cause like a spastic type of bladder. Real tight bladder. They're going to hold on to urine often, have big urinary retention. And then on the other end, so the lower injuries, so your lower thoracic, your lumbar spine type of injuries, you're going to have more of that flaccid bladder and your flaccid bowel as well, your bowel involvement. So you're not able to retain that bladder control like you should. Either way, my bladder control is affected. Either I'm holding on to too much or I'm not able to hold on to it at all. So urinary issues are going to be a big factor with your spinal cord injuries. So these are a lot of different things that can cause stress within the body. A lot of different stimuli. Just think about it. If you're constipated, are you stressed? Anna's stressed. Nobody else is stressed. But when she's constipated, she's stressed apparently.
Definitely.
Or if you're bowel incontinent, you're stressed all the time too, right?
Yep.
Or if you have urinary retention, your bladder's real full. That's causing a lot of stress within the body. That hypotension, that's going to cause stress within the body. So all that saying, all these stressors, all this involvement within my body could lead to something called autonomic dysreflexia. Autonomic dysreflexia. If you don't know how to spell it, it's on the next slide. Okay? Autonomic dysreflexia. Very dangerous condition. So some type of noxious body or skin stimuli. So something like that constipation, something like that urinary retention, skin issues. Maybe we haven't turned my patient on in a while. It's causing that pressure point, pressure sore. Maybe their arm is up against the side rail. It's causing direct pressure point on that site, that area. So some type of stimuli causes rapid, massive, unchecked sympathetic response. Your biggest thing with your autonomic dysreflexia, elevated blood pressure, dangerously high blood pressure. That's what takes us into the second box right over here. Sudden, significant rise in systolic and diastolic blood pressure. With that, we're going to have our bradycardia as well. Let's talk about some other key risk factors. We talked about bladder distension. We talked about constipation. The bed rails are involved, maybe. What other things can we think about?
Seizures.
Yeah, that could cause some stress, I guess.
Pain.
Pain, that's a good one. What if their clothing is too tight? Is that going to cause some stress along the skin, causing a noxious stimuli? I mean, this is like real simple stuff sometimes. Stuff you gotta think about. Stuff you really don't even think about in your day-to-day care of your patient. But it matters with these injuries. Epididymitis, that's another big one. What is that? Anybody know? It's not on this one. I don't have a picture of it. Inflammation within the testicles, okay? The epididymitis is a cord, a cord along the backside of the testicles. Gets inflamed. We can also have what's called testicular torsion. It's EPI, DI, DY, MI, TIS. You also just have the testicles as they hang, causing that pressure point as well. Hemorrhoids, fluctuations in the temperature, several different factors. Main thing is some type of stimuli is causing this sympathetic nervous system response. And then your big takeaways are going to be in this column over here. Sudden increase, sudden rise, dangerously high rise in your systolic and your diastolic blood pressure. With that, I'm going to have a slow heart rate. I'm also going to have some diaphoresis above the level of the injury. So let's say I have a T1 or a thoracic 1 at first vertebrae within my thoracic column, injury. Anything above that lesion, above that injury, usually kind of in your face, your neck, your shoulders, going to have that increased diaphoresis, increased sweating. Also going to have flushing, redness. So like my cheeks all the time, that's what we're going to see. Goosebumps. You may have your patient report spots in their vision, blurred type of vision. Anxiety, stress, kind of that impending doom. And a throbbing headache. I would know this slide, okay? How do I fix that issue? Prevention is going to be the number one thing. Let's not let it happen to begin with. So it's the constant matter on constantly monitor their bladder habits, their bowel habits. Make sure we frequently roll our patients. Make sure they don't develop some type of pressure injury. Make sure they have that real loose fitted clothing. Slushy. Make sure you check on your male patients. Make sure they're not twisted or anything. But if we start to sense or think that our patient may be going into or experiencing this autonomic dysreflexia, my first initial intervention is going to be to raise the head of the bed immediately. Why is that? Thoughts?
Airway.
That could be airway, but it's more about
Draining.
the rise of the blood pressure.
Because it does something, it drains.
So that sudden increase or rise in that blood pressure, when I raise the head of the bed, it's really decreasing my blood pressure overall, especially within the brain, within the cerebral space within the skull, causing a decrease in blood pressure there because it's shunting my blood, pushing my blood back down through my thoracic cavity, using gravity as a help. Raise the head of the bed. Notify your provider for blood pressure management. I gotta get something to get my blood pressure down pretty quickly. Sometimes in your neuro units, you'll have something already on board. So something PRN to lower my blood pressure overall. Because they want it in a very specific window. They want to increase perfusion, increase your blood pressure, but they don't want it too high on the other end so they stroke out. So it's a very delicate balance. So if something is already ordered, I can go ahead and give that for my blood pressure management. So some type of, usually some type of IV beta blocker, maybe some type of nitrate or nifedipine. Sometimes they may be on long-term clonidine, scheduled clonidine. Main thing is I want to get my blood pressure down. And then I've got to figure out why they went into this autonomic dysreflexia in the first place. I got to eliminate that stimuli, that noxious stimuli that's causing this event. So if it's urinary retention, let's put in a Foley. Let's drain that bladder. Fecal impaction. Somebody's got to go digging, right? Or maybe I get some GI stimulants on board. Some type of laxative on board to hopefully help that out. But with a fecal impaction and autonomic dysreflexia, I need something a little bit quicker than some of those laxatives. All right, so I have to fix that fecal impaction. Skin injuries, that big skin assessment. Make sure their limbs are not hanging on the side rails, not touching the side rails. Make sure the testicles are not turned. You don't have that testicular torsion. Make sure there wasn't some type of sudden increase in temperature within the room or within your patient. Let's fix that. Hopefully that'll help with your symptoms. With that, maintain that blood pressure. As we give those medications, as we eliminate that stimuli, that blood pressure should come down. I don't want this elevated blood pressure for a long period of time, a sustained period of time. Then I could be at a great risk for stroke. So I really like this picture on this side. Shows you T6 or below. Usually we're going to have that autonomic dysreflexia, things that are going to cause the autonomic dysreflexia, the symptoms you'll see as well. Okay? Questions about autonomic dysreflexia? This is also box 37.3. Box 37.3 on page 926. 926. Some safety, quality care measures for your autonomic dysreflexia, emergency management. But big things, raise the head of the bed, give something for blood pressure, figure out what's causing the issue. Find that stimuli. So in a spinal cord injury, what is my role as a nurse? Big things in red. Prevention of that neurogenic or hypovolemic shock. So I'm doing that thorough, continuous assessment of my neurosystem, of my cardiovascular system, maintaining my airway, my breathing, my circulation. If I need to intervene, speak with the physician to get them on board to intervene. But that IV hydration is key with any type of shock, remember, with our shock protocol. Monitor for those signs and symptoms of that autonomic dysreflexia. So all these types of things. Monitor for those. Make sure that your patient is not going into autonomic dysreflexia. That's an emergent situation, something we need to take care of. Got a lot of different options to medications on board. Atriprine for your for your bradycardia, for your low heart rate. That can help out with your neurogenic and hypovolemic shock, increase that heart rate, also help out with your blood pressure a little bit. Your two big ones for your vasopressors are going to be your phenylephrine and your dopamine. They're more neuro involved compared to your other ones. So your phenylephrine and your dopamine are going to be two of your big ones. Everybody's sneezing. Dextran is just a blood volume expander, helping out with that circulating blood volume to help out for your neurogenic and hypovolemic shock. While we're talking about neurogenic shock, let's kind of refresh our memory a little bit. What type of symptoms are we going to have?
Low blood pressure, high heart rate.
Yep. So we might have some hypotension, so anything, let's say systolic less than 90 and MAP less than 65. Initially, we may have higher heart rate to compensate, but on the tail end, we'll have some symptomatic bradycardia with it as well. Fluctuations in temperature, not able to maintain my temperature, so I might have a super high temp. I might also have a super low temp as well. So those types of things. Follow-up care. Follow-up care, and our main goal, oh no, what happened? Our main goal with our follow-up care is going to be to get them back to the best functioning as possible for their activities of daily living. Get them back to close as normal as possible. There might be a lot of modifications with those activities of daily living. If they're paraplegic, they may need to get a wheelchair at that point. Do they have a ramp at home? Do they have stairs? Are they in a one-story home versus a two-story home? Is the wheelchair even able to fit through the door? Do they have vehicle or reliable transport to get them home, get them back to doctor's appointments, those types of things? There's a lot of modifications and stuff that I have to think about. So social work is going to be your friend. Home health is going to be your friend. They're going to need those things for this long-term period of care. Physical therapy can be involved as well. Strengthening up those muscles, anything that they have weakness with. Even if we're not strengthening those muscles, preventing the development of contractures. Going through those range of motion type of exercise may not necessarily build up that strength, but it can also help with the contractures, stretching out those muscles, those tendons, going through that motion. And then mental health support as well. That's also going to be a big one. You imagine being a 18, 19-year-old kid getting in a massive car wreck and then being told you never walk again. That's going to have a significant impact on their life, right? Mental health support is going to be crucial. It's going to be big. What about a all-star football player at the college level is fixing to be the #1 overall NFL draft pick, and then he severs his spinal cord. Now he's permanently in a wheelchair, quadriplegic. That's going to take a toll on somebody, okay? So think about those things. Now, how am I going to prevent that secondary injury from ever occurring? So remember, that secondary injury is something that's not related directly to the impact or the force or directly related to that primary injury. It's a result of that primary injury, okay? So any kind of fracture, any kind of movement along that vertebrae or that spinal column is going to cause maybe an injury to that spinal cord. So our main goal with our secondary prevention is going to be that stabilization of that spinal column. Short term is going to be that hard cervical collar. So everybody's kind of seen that where they put that big C collar along them, especially in like car wrecks and stuff like that. And you'll just see almost they put it on prophylactically just to stabilize that cervical spine until they get imaging and other results to make sure that there has not been an injury that has occurred along that cervical spine. So some just type of cervical C collar. Proper sizing is important. Skin integrity is important as well. Make sure you're looking up underneath these cervical collars. You're not just leaving them on and forgetting it. You gotta look at the skin. Now remember, airway, breathing, circulation is important, but I also want to maintain spinal column stabilization. So if I need more advanced airway and opening up that airway for that airway management, jaw thrust is going to be what's recommended. So if we think back, just a normal person that we're fixing to do CPR on, and we're doing the ambu bag, we do the head tilt chin lift maneuver, right? To get that tongue up and back and out of the way so I can provide those adequate breaths with that ambu bag. Don't want to do that here. I could cause an injury to that cervical spine, to that cervical column, increasing the effects of that primary injury. So I want to maintain that spinal stabilization by using just a jaw thrust maneuver. Not quite as effective, but still effective. With position changes, that's going to be very important, right? As I'm rolling, as I'm turning, I have a high chance of getting that spinal column out of line. I got to maintain that alignment as much as possible. So complete log rolls are going to be important. I'm not causing any kind of rotation, any kind of imbalance along the spinal column. That can be very difficult, but we have to change positions. We have to maneuver. We have to roll. We have to take care of our patients. In the very acute phase, physician may not want you to turn at all, or they may put them on some type of brace or backboard that keeps them in true alignment and keeps them true to rolling. And then several days out, they may change the level of activity where you can start to do some of these types of position changes. Other side, for the surgical intervention to stabilize that spinal column, usually we're going to do some type of spinal fusion type of surgery. So we basically put a rod all the way down the length of their spinal column and just stabilize that spinal column. And you basically screw along all of those vertebrae, keeping it in line at all times. They have the best posture you can ever think of because it's just a straight rod down the back. So, everybody remembers when my brother came in and how he was sitting like straight up as a board? He's got spinal fusion all the way down. So keeps it perfect alignment from there, okay? Skeletal traction, it also kind of fits in with this halo fixation device, which is going to be right here on this side. So they actually have pins within the skull that keeps it in line, and they wear this vest that keeps that cervical spine in perfect alignment. You can also keep that traction on this halo fixation device to kind of almost pull apart that compression, keeping that spinal column in perfect alignment from there. There's going to be some type of order set, some type of care that's involved with those halo devices, with those skeletal traction, because they actually have pins that are placed in that skull. So you have to take care of those. So infection prevention is going to be key with that. Again, they're going to have specific orders when to roll, when you can't, how high up in the bed they can be. Can they sit semi-Fowlers, high Fowlers? There's going to be several things that are going to be involved with within this, okay? Questions about this? No? Okay. All right, let's switch gears a little bit further. Traumatic brain injuries. Some type of force, whether it be direct or indirect, causes trauma or injury to that cerebrum, to the brain, within inside that skull. Not part of the congenital, not part of some type of neurodegenerative. So something that happened to your vasculature within your neurosystem, within your brain. Some type of direct force. Symptoms can be a wide range of different things, varying different things that can have more permanent effects or something temporary that kind of comes and goes, but will last for several weeks up to months. Things like changes in LOC, sensory perception issues, mobility type of issues, very similar to your spinal cord injuries in a lot of ways. Direct injury, that's how we're going to define it. Either direct injury or an indirect type of injury. So direct injury, direct impact to the skull. So some type of direct blow to the head. So somebody hits you in the head with a baseball bat. That's a direct blow to the head. Indirect injury. Some type of force, some type of blow to another part of the body. But then it rebounds, reciprocates to within the brain. Then you can further break it down into acceleration versus deceleration types of injuries. So acceleration injuries, again, that baseball bat to the head causes that sudden movement, almost that kind of that whiplash effect, causing that brain to kind of slosh around and hit within the skull. And then say you're running, let's talk about a football player. He's running, he gets tackled, but it's called for targeting. He has that movement of his head, but then he hits that kind of brick wall or kind of that other football player and causes that sudden stop motion to occur. So that deceleration injury. Or you're within a car and then you hit somebody head on and you kind of move forward. That could be that deceleration injury. Moving to an abrupt stop. With our traumatic brain injuries, we also have primary versus secondary type of brain injuries. With these, it's very similar to our breakdown of our spinal cord injuries. Primary injuries occurs at the time of that injury. It's the result of that direct impact, that direct force that has occurred to the skull, to the head. So that blunt force or that penetrating trauma that's occurred to that skull. We classify these in a couple different ways, 4 different ways. We have focal versus diffuse. So focal and diffuse are kind of paired together. And then you have open versus closed, so they're kind of paired together as well. Focal, really confined to a specific area of the brain, causing localized damage in that area. So if we kind of look at our brain, it's going to do it tonight, I'm not sure. It's not. So if we look look at our brain, it's going to be in one specific spot, one specific area within this section. And then we look at the opposite, diffuse. It may start off in one localized area, but then it radiates out and affects other areas within that brain. So that's how we kind of tell the difference. Focal is more obvious, more present at the initial site of injury. So soon after the event, we can really tell the significant damaging effects of the injury. Usually some type of CT scan or MRI is going to detect this, be able to see the extent of the injury. Our diffuse injury, more of us microscopic level. Not able to really see this on the initial scans. It may take several CT scans or several MRIs before we see the full extent of this injury. This injury can occur for a long period of time before it fully develops into a big primary brain type of injury. All right, let's look at open versus closed. Pretty self-explanatory on this one. All right, open. Skull is either fractured or penetrated by something. So something like a gunshot wound. You really have to swing a knife to get it open into the skull. But so some type of gunshot wound or a fracture within the skull. Some really big force. Again, maybe like a baseball bat. A really big swing causing a fracture with that skull, opening it up. Big things with that, it's going to really compromise my brain tissue, my brain integrity. Once I have that opening there, my brain is going to flush out, swell out to that site. Plus, you gotta think about the skull. It's a protective barrier. It's protecting injury from occurring to that cerebrum, but also protecting other things from coming in. Environmental factors, infection, these like microscopic organisms, dirt, dust, smoke, all kinds of different things. It's causing that protective barrier. So now we're compromising that, and we have a great risk for infection. Closed. Integrity of the skull is intact, but damage to the brain tissue still occurs. Either some type of increased intracranial pressure, some type of swelling or edema that's occurred in the brain, maybe some type of internal force. Maybe there's a slight bleed that's been happening over a period of time. Maybe some of my vasculature was compromised with that force or that trauma, causing a small brain bleed within there. All right, let's look over at the secondary brain injury. Secondary side over here on the right side. Anything that makes the primary brain injury worse. Not necessarily caused from the direct impact, direct force of the traumatic brain injury initially, but anything that's going to worsen the initial effects of the primary brain injury. So very similar to your secondary and your spinal column. These all kind of run similar to the same. So things like hypotension. Maybe I was in a hypovolemic shock or neurogenic shock. Hypoxia, I had a compromised airway. With that increased swelling, that increased edema, that increased intracranial pressure, that's causing stress on that vasculature space, decreasing that perfusion. So I can have some ischemia involved as well. Again, big thing, extension of that primary injury. That's our key with our secondary brain injury. Now the next few slides are going to be results of a primary brain injury. Things that we're typically going to see are things that can result from a primary brain injury and things that can lead to a secondary brain injury as well. First things first, increased intracranial pressure. Remember that skull is a closed source. So if I have a significant rise in our cerebral spinal fluid or a significant rise in swelling or edema within that brain matter because of that injury, that's going to cause excess force, excess pressure within that intracranial space. Between your brain tissue, that blood, and that CSF, all that together is causing that excess pressure, excess force, causing that injury. Maybe it's causing excess force on that vasculature space, or direct force on that brain tissue, that brain matter, causing that injury. Normal ICP is 10 to 15. Short-term increases, probably not a great thing, but it's not really a bad thing. So what could cause like a temporary increase? What if I cough? Is that going to cause an increase in my intracranial pressure?
Yes.
All this sneezing that we're doing right now, that's causing an increase in our intracranial pressure, right? Sometimes when you sneeze, doesn't your brain hurt a little bit? Mine does. I don't know if that's normal or not, but it does. Okay. What about bearing down to go to the bathroom? That's causing an increase in intracranial pressure. But usually those go back down. They resolve on their own. Really no harm. But if I have sustained intracranial pressure, that's what's dangerous. That's the key, sustained. So increase, that should have a P on it, just says IC, so increased intracranial, I guess. But increased intracranial pressure greater than 20 for sustained long period of time. That's what we're going to consider as dangerous. Now, how does my body cooperate? How does my body help out with that? First things first, my CSF is going to do some changes. It's going to do some different things. That's what's going to compensate first. It's going to move into other areas, other spaces. So first things first, it's in the subarachnoid space. So I may actually have my patient report that they have a stuffy type of nose because they're feeling the effects of that CSF moving into that subarachnoid spaces. So kind of that stuffy, runny type of nose. And then my body's also going to compensate by just absorption of that CSF fluid. I can also intervene too and drain off some of that excess CSF fluid while monitoring my ICP to help out overall, help my body compensate for that increased pressure, allowing for that body to go through those changes, decreased swelling, decreased edema, hopefully get through that initial injury, and then I can take that brain drain out, or that drain that's causing the CSF fluid to drain out, and just kind of help my body temporarily through that initial phase, that initial injury. Other things too, secondary compensation is going to be something like your decreased cerebral blood volume. So I'm going to shunt my blood away from the cerebral area. Now, if all these things fail and I don't have immediate intervention or quick intervention, that's why I'm going to have that increased swelling edema. That's why I'm going to have that decreased perfusion, causing stress on that vasculature, causing ischemia. My brain starts to swell out, causing almost like a pressure sore, pressure injury. As that brain kind of presses up against that skull, it's not able to relieve that stress in any way. It's not able to move in any other direction because that skull is in an intact, hard, compact area. It's not able to move in any direction. With that, that's where you potentially see taking apart away of the skull or the burrow holes, allowing for that swelling to expand as much as possible. Several days later, then I can put back in that fragments of that skull back in place. And if it goes untreated for too long, the only place it can go is down. That's where we have that herniation of that brain tissue, of that brain matter. When that occurs, pretty much death is shortly thereafter. You don't really come back when your brain herniates. So basically that opening at the very bottom of your skull where your spinal cord attaches to the brain tissue. It herniates downward. Right? That point is pretty much too late. Now, this is not in the initial slides that I put out, but I can repost it. I added this later because I felt like we should look at it. So this is very similar to like an arterial waveform. So an art line in your ICU. Everybody's pretty much seen an art line in the ICU, right?
Mhm.
The red waveform, got a 0 to what?
The
The phlebostatic axis, yeah, that one. The phlebostatic axis, that armpit level, okay? Not gonna zero this to the phlebostatic axis, but it is giving me a waveform. It is giving me a pressure to monitor within that intracranial space. So it's measuring directly that intracranial pressure. Then I can give medications, I can drain off some excess CSF fluid to help out and decrease that intracranial pressure, and I can constantly monitor it, and it's a delicate balance to keep it within that range. So remember, above 20, and that's not where I want it. I want it below 20. So you have it directly inserted within the skull, and it comes up and has a system. It has a pressure management system, also gives you a waveform down here, but then it also has a CSF drain as well, and it kind of collects in this chamber right here, and it's kind of a slow, steady drip every now and then it has a big collection bag down here at the end. I think the next slide, yeah, here you go. Really shows it. So up here, that's kind of where your cerebral spinal fluid is going to accumulate. And it has a really small chambered area, and so you can have a really accurate measurement of how much cerebral spinal fluid is actually draining out of the system. And then you have a three-way stopcock. So you'll go in every hour, take a measurement up here, turn your three-way stopcock, and allow it to drain in this bag. Turn it back up, and then you'll come back in the next hour, and you continue to do this measurement every hour or so, or whatever the order says, basically. But that's a rough idea of what you're gonna do with that section. And of course, here's kind of the big picture of it as well. This is gonna be your line that's connected to your patient. And then you have your laser level right here. Anybody know where we zeroed this to? An ear? Yeah, it is an ear. Where part of the ear?
The
middle
hammer
of
and
it?
the anvil.
The hammer and the anvil. Wow, we're more specific. Can you see your hammer and anvil?
Your cotton.
No, like so, not yours.
Your tragus. All right.
It's-
So that little flap right there on the middle part, you know? I don't know how to describe a tragus other than it's the little middle part. The opposite part of the ear, you know, that's attached to the,
the one
you know what I'm talking
attached
about,
to your-
Natalie?
I don't.
How do you-
Are you talking about this part? Like,
Yep, that part.
oh,
I guess you get a tragus piercing, can't you?
I want,
Yeah.
I want the pressure piercing.
That's the one that's supposed to relieve.
Anyway, that's where you're leveling it to. That's where you're zeroing it to, okay? And that gives us the most accurate intracranial pressure. Several systems. This one has a laser pointer to get a very accurate measurement. Baptist South, it's the first time I took care of one of these, and I had to watch a YouTube video on how to set it up. Very
That's
scary.
nice.
Yeah, it was great. I was a travel nurse, and they're like, "You take care of these. Have at it." And I was like, "Well, okay." So you just got to figure it out. But they had a piece of string right here. That's how the system was designed. They didn't just tie a piece of string to it.
Oh,
And
okay.
you put the piece of string directly to the tragus, and you get it leveled as much as possible. And that's how you fix it. Then I had a charge nurse come in and help me through it too. So know your system, know your equipment is the moral of that story. They just thought I was a travel nurse and I should know all things, and I didn't know all things. So that was scary. Very sick patients too with these. They also have very specific orders on how high they should raise the bed, how low you should raise the bed. You're usually gonna have them in kind of almost a high Fowler's situation. You're not trying to drain out all their CSF fluid as well. So if you drop them below a certain point, then it could cause a lot of drainage of that CSF fluid. So I have all these signs posted everywhere too, that you're not able to lay flat, that kind of stuff. So you have to get creative with chest x-rays and different things like that as well. Okay. Pretty cool setup. I don't like neuro that much. This was very scary to me. This is the one time I was scared, guys. So you always ask me when I was scared of nursing. This right here was one of them. Neuro ICU was not my friend. I really liked it, but it is what it is. Okay. Intracranial hemorrhage also can be a result of a traumatic brain injury. So remember, your primary versus your secondary injury, it could result from either one. So primary is that direct impact caused an intracranial bleed, intracranial hemorrhage, or that direct impact caused an issue in my vasculature, and then eventually my vasculature caused a bleed. Okay. Things like vascular sharing, skull fractures, penetrating trauma, so like a gunshot wound, all these things can cause bleeding within that intracranial space. There's 4 big main types that we're gonna have, that we're gonna talk about. Epidural hematoma versus a subdural hematoma. And then you have your subarachnoid and your intracerebral hemorrhage as well. And that's going to be kind of your 4 main types. All of this excess bleeding, all this excess edema is causing all that pressure within that brain. So it's a very life-threatening, very serious type of situation. Go one more slide over. We'll come back. So here's your epidural hematoma versus your subdural hematoma. So here we have that skull fracture, but we have this accumulation of blood in between the skull, in between the dura mater, so in between the two. That is the difference in your epidural hematoma and your subdural. So your subdural, you have your dura mater, your dura layer right here. It's not in between the skull and the dura, it's on the other side. So dura mater, and then you have your subarachnoid space in between those two. So your epidural, in between the skull and the dura mater, subdural hematoma, in between your dura and your subarachnoid space. That's going to be your difference there, okay? That's how it is in terms of words here. So between the dura mater and the inner skull, probably with no signs and symptoms of these two as well. So epidural wise, lucid interval. So basically thoughts of clarity, you're up, moving around, doing whatever, but then you have moments of unconsciousness, followed by rapid increase in your intracranial pressure. Frequent neuro assessment. So what kind of big neuro things are we going to see? Perla. Perla is going to be good. Pupil or equal, round, reactive to light, and accommodation. If they're not round, they're oval shaped, or you're going to have a little blip on one side or the other. That's something significant, something we need to report. What other neuro stuff? Stagmus, yes. What about something real simple? What's really the first initial
Orientation.
sign? Yeah, orientation. Your level of consciousness. If my level of consciousness begins to decrease, already in the back of my mind, I'm thinking, all right, something's happening with neuro. Especially in these traumatic brain injuries. Something has gotten worse. Maybe they have developed some type of epidural hematoma. Subdural hematoma. Remember again, between the dura mater and that arachnoid layer, a subarachnoid layer. Usually this is more slowing, ongoing, progressively gets worse. So you have kind of different phases. You have acute, subacute, and then chronic. So acute's within that first 48 hours. So remember, this is slow growing. Then you have 48 hours to 2 weeks, 2 weeks to months. And any of these signs and symptoms really can present themselves at any period of time. So it's just kind of a progression of these signs and symptoms. This one can happen in older adults, not even with some type of blunt force trauma or primary injury. When people get old, they start to leak, right? Have that old peopleitis. And so with that, vasculature begins to weaken, begins to tear. And so then I can start to develop a small trickle or small bleed, causing that subdural hematoma. Old peopleitis is not a medical definition. That's an Aaronism, so don't write that down.
Is the speed due to the fact that one's is arterial and the other is venous?
It's microscopic, real small, so it's just kind of like a tiny little bleed. But you could have venous bleed as well with it. So again, it's just kind of that microscopic approach to it. Now, intracerebral hemorrhage. So now we're getting within the brain matter itself. We're not in between the layers of the skull, the dura mater, and then the subarachnoid layers. Now we're actually in the cerebral space. So it's pretty self-explanatory there. Inside the cerebral space. Intracerebral hemorrhage. So any type of artery and vein, stress, tear, injury, trauma to that space. Signs and symptoms are going to be pretty close to your epidural and subdural hematomas. Okay. We can also further classify our types of traumatic brain injuries into mild, moderate, and severe. There's also a great table on page 956. It's table 38.3. Table 38.3 on page 956 of your MedSurg textbook. And it kind of shows you the differences in mild, moderate, and severe. Really, it kind of breaks this down and puts it in a table format. So if you want to look at it in a table format, you can. When we're grading these or typing out these traumatic brain injuries, our Glasgow Coma score really comes in to play. So let's look at our Glasgow Coma scale and we'll come back. Glasgow Coma scale is based on 3 different things: eye-opening response, verbal response, and some type of motor response. The lowest score you can get on this is a 3. But the higher the better. You don't want a low score. This is not golf rules, okay? 3 is the most severe, unconscious type of patient, comatose type of patient. So you'll hear GCS a lot, and it does a really quick assessment, and they'll use it a lot in the ER, especially out in the field too. Paramedics and medics in general use this a lot in their stuff, and you go here and report GCS of 13, and then you can kind of know from there what's happening. But for eye-opening response, are they opening up their eyes just because? That's spontaneous. They're opening their eyes, moving around, looking. Or am I having to create a painful response? So I'm doing like a sternal rub, a serious sternal rub, and that's the only way that I can get them to open up their eyes, to have that eye-opening response. So it kind of fluctuates between this scale right here. You kind of see, I'm not going to read through 4, 3, 2, 1, but that's how you see that there.
Now, do these, numbers vary depending on what hospital you're at, or is this across the board?
This is across the board, it's pretty standard. Patients can also fluctuate too, so just because they came in with a 13 GCS doesn't mean they can come down the scale. So they can kind of go back and forth between the scale as well. Verbal response. Are they confused? Are they oriented? Are they talking at all? Are they making sense? Are they making words, sentence structure? Are they just making sounds in general? Or they're saying nothing at all. So then you have none down there at the bottom. Motor response. And this one does not have a 1 down here at the bottom. But 1 would be no motor response at all. I think this one does, yeah. So down here at the bottom, it says no response. Are they able to squeeze your hands? If you tell them to lift their arm up high in the sky, are they able to do that? If not, if you create a painful stimuli, so you do that sternal rub, are they localizing to that pain? Are they kind of crunching in or trying to grab your hand and get you away from that area? Or if you do a nail bed and you pinch it down real hard, are they kind of flexing from that? And then something like an abnormal flexion. So they're doing that decerebrate or decorticate type of posturing or abnormal flexion. And sometimes they'll just have that full extension of their motor response and then none at all. Main thing is it's a quick, rapid assessment of my patient's status overall. The low end is a 3, the high end's a 15. Several different things. Yeah, yes.
You do have to DC all sedation before you do these, right?
Yeah, we're gonna talk about sedation in just a second.
Okay.
Like I said, this can happen for a lot of different reasons. Some type of neuro injury, some type of metabolic process, some type of trauma, maybe some drug influences as well. She said sedation, but it could also be things like marijuana use or methamphetamines, some of the over-the-counter stuff. Anything really that can impair your level of consciousness, it can affect your GCS level. Here we're just talking about it with traumatic brain injuries, but it could go across the board for a lot of different things. Again, it's frequent assessment of this GCS score. It can change, it can fluctuate. We can go from mild to severe back to moderate. It goes both ways on the spectrum. So taking the GCS into account, we're looking at types of traumatic brain injuries. We have mild. So loss of consciousness, less than 30 minutes. They don't even have to lose it. If they don't, that's fine. This still might be considered a mild response. GCS is really not involved in this. This is going to be in that mild section, so that 13 to 15 on your GCS. Usually it's going to be more on the upper end, on the 15 range. Symptoms are going to be real mild with this. They might have some just mild neurodeficits, so maybe just some tingliness, numbness inside their extremities, maybe some weakness, that paraparesis, something like that. Okay?
Can I say an interesting thing?
Yeah, go ahead.
I found a study on multiple mild traumatic brain injuries, specifically like for football players. They can change their, you said change in behavior, it can change their personality to become like more violent. They did a random study for like football players and their correlation to doing violent crimes.
I think I saw something like that.
Yeah.
And there's a documentary on Netflix with that Florida player. I think that might be some involvement with that too.
I haven't seen that one, but I saw the study.
I don't know. It's not a study related to brain injuries. He was just a violent person. No, I don't know if that's involved with it. But yeah, football players, that's kind of the people we think about with these types of brain injuries. The big one I think about is Tua Tagovailoa. That plays for the Miami Dolphins. He also played for Alabama for a while. can't help what school he goes to. That might be part of his injury problem. But went and played for the Miami Dolphins. He's had a lot of head injuries here recently. And he's very forgetful where he's at sometimes. Sometimes he doesn't even remember playing a football game. He has severe headaches all the time. You'll see him collapse on the field where he just locks up and has this just extension part. Look up some of his videos of when he gets tackled, and he has a lot of these symptoms right here. It's kind of scary, but he still wants to play football, and I don't understand that whatsoever. But it's what he loves. So we talked about mild. Let's move to moderate. 30 minutes to 6 hours at this point of loss of consciousness. That's how we're going to distinguish it more into this moderate category. Now our GCS is really going to come into play. So now we're in that moderate scale, 9 to 12 scale on our GCS. Maybe they're not as responsive. They're not opening their eyes spontaneously. Maybe I have to get a painful response out of them before they open their eyes. Maybe they're doing incomprehensible sounds. They're just kind of mumbling a little bit, not really making a whole lot of sense. Maybe they have that abnormal flexion. Maybe that decerborate or decorticate type of posturing. Anybody remember what the difference is with those? What's decorticate? All right, decorticate's like that apparently. All right, decerborate's what? Outward, right? Decorticate towards the core. Decerborate's outward, right? Okay. That's a great example, Chuck. I like that. At this point, now I'm really worried about specific issues toward the brain, some type of specific brain injury, whether it be focal or diffuse. With your mild, I'm not necessarily as worried about it. It's a very mild type of just easy, simple injury. Nothing too severe. As we get in these categories, the closer monitoring we're going to do for these signs and symptoms of that traumatic brain injury. That increased intracranial pressure. Maybe they develop a hemorrhage. They start to have those neurodeficits. They have that change in LOC. Again, they can also potentially go from one to the other as well. And then severe, longer than 6 hours. Remember, we're on that new scale, on that severe scale, 3 to 8 on that GCS. We're really going to see a significant injury, significant impact pretty early on these. And this is kind of the most severe, most emergent type. And so we're going to do some pretty significant monitoring, ICP, manage it, might get some medications on board. We'll drain off some excess CSF fluid, blood pressure management, hypovolemic, neurogenic shock as well. Overview, what the things I'm going to assess for. Big things, your GCS scale. How do I evaluate that? How do I assess that? That's what we're going to think about with our traumatic brain injuries. Let's get a GCS, let's get a baseline, and see if it fluctuates one way or the other. Signs and symptoms are really going to vary depending on if it's that mild, moderate, or severe type of brain injury. And that's when we're going to start to see that increased swelling and that increased edema. That's going to increase our ICP or our intracranial pressure overall. Remember, big things neuroassessment-wise, changes in LOC. That's going to be our first one. That's going to be that slight, subtle thing that we're going to see before all this other big, bad stuff is going to occur. You may just see a slight change before that big emergent event occurs. Also going to monitor ICP, hypotension, hypoxemia, maybe some CO2 retention, depending on if my airway is compromised. With these traumatic brain injuries, I'm also going to do my spinal cord precautions with it as well. Maintain that alignment. Very similar to what we talked about with your spinal cord injuries. Two big things. Adequate cerebral perfusion, and then prevent that secondary injury from occurring. First things first, check that airway. Breathe in circulation. Your ABCs of your patient. Gonna check that airway. Making sure those neurodeficits are not causing any effects on my respiratory system. So things like your diaphragm. Making sure I don't have some type of irregular breathing pattern. Maintaining or retaining that CO2. Maintaining my oxygen levels. Maybe I need to get a blood gas. Make sure my pH is normal. Make sure my PO2 is normal. And if I have to, put them on some type of advanced airway system. Neuroassessment. And I mentioned earlier, PERLA. So pupils equally around, reactive to light, and accommodation. Don't just write this in your note like y'all all do, because I know y'all don't all do PERLA all the time, but you tell me PERLA anyway. Please actually do this. This is important as part of your assessment for your traumatic brain injury patients. You're gonna get tired of assessing these things, but a good, thorough neuro assessment is gonna be key. They can also have a great risk for Cushing's triad, so severe hypertension, that widened pulse pressure, so high systolic, very low diastolic, and bradycardia. Those three together has this kind of trifecta, this emergent event called Cushing's triad. That's an emergent situation, so I need to get those under control. Trending GCSs. And then level of consciousness. Remember, I keep stressing the importance of that. That LOC. It's going to be your most sensitive indicator, your most subtle approach. So another reason I don't like neuro ICU, can I sedate these patients?
Not supposed to.
Yeah, how do I know if they have a change in LOC if I sedate them? I don't, right?
You can.
Yeah, I wish.
I think paralyzed my wife for 2 months.
See, I mean, you can. There's certain instances, there's certain things you can, but for the most part, they really hold off or back off on that sedation. Or they do the sedation trials. Periods where I wake them up fully, see what type of neuro response I get, see the full effect of that traumatic brain injury. And kind of go from there. But for the most part, they really don't like for any type of sedation to be on board because they want to track that level of consciousness. So pupil area assessment, and then again, are they posturing? Disturbed or decorticate type posturing, the weakness of that, the sensory perception part of your weakness as well. Are they able to feel things within their extremities as well? Visual changes, and then CSF leaks. How do I know if it's a CSF leak? Send it to the lab. Okay. I got a real simple test. I don't even have to send it to the lab. I could taste it, couldn't I?
I mean, I would hope not.
Sweet.
You could taste it, and I did that back in the day. It's sweet. It is
It's like it
glucose.
has a yellow tinge to it.
It does have a yellow tinge to it, but there might also be some blood as part of it as well. But back in the old days, they did used to taste it. And it has a high sugar content. So Sam's not gonna be a neuro nurse as well. So we have what's called the HALO test. So I take a drop of fluid. So whether it be you see a little bit of a leak out of their ear. Sometimes it can kind of drain out of your nasal passage as well, but most of the time it's out of the ear. I take a drop of it, and then I'm gonna have this halo ring around the outer edge of that red spot, that blood spot on that gauze. So you just take a simple little gauze. Sometimes they'll take a little bit of a piece of filter paper. A lot of times it's just kind of one of those 2x2 gauzes. You drop it dead center of this. The way the cerebrospinal fluid is made up, it goes to the outer edge and it kind of creates this halo effect, this circular effect. If you see that, then there's the presence of CSF fluid within that fluid, I guess, within that blood. Okay. And then there's further testing that you can do, but this is kind of that initial phase. You can also get just a glucose monitor and test that drop of blood. If it has a high sugar content, then you can potentially have some CSF fluid mixed in with it as well. Okay. Let's talk about a couple medications. Really the two big ones is going to be mannitol. Mannitol is indicated for any type of cerebral edema or elevated intraocular pressure. Usually we use it for increased intracranial pressure. It's an osmotic diuretic, so it pulls water out of the extracellular space, so it kind of helps decrease that swelling within that brain tissue. And then I can combine it with furosemide and kind of use it as a diuretic effect and kind of flush out that extra fluid within that cerebral space. More effective as a bolus dose, but you can use it as an IV drip form as well. It's got to be with a filter, has to be filtered. It's a very thick, viscous type of drug as well. It's got a yellowish orange tint to it. The big thing I know that it's working is my change in urine output. If I don't see an initial change in my urine output, then it's not absorbing enough water, enough volume as it needs to. Then I can give a secondary dose if needed and hopefully affect my urine output. That combined with my furosemide, my Lasix, should be able to diurese me and have that increased urinary output. With that, I can have dehydration. I can also have some electrolyte disturbances as well, because that shift of fluid, that's that shift of sodium in there as well, is going to cause some electrolyte imbalances. Okay. And then we have furosemide as well. Everybody pretty much should know what furosemide is. It's a loop diuretic, right?
Mm-hmm.
Okay. Is it going to affect my potassium levels? It should. Okay. It's also going to affect some other electrolytes as well. It can also cause some dehydration. But again, our goal is to decrease that intracranial pressure by pulling off that excess volume, that excess fluid, and diuresing it out, urinating it out. Okay. Questions about that? Nope. Okay. All right. Last thing, and then we will get out of here. Just a quick review. We don't have to be on